Hi guys, can you hear me?
Yes.
Okay, cool. All right. Wanna start? Let's use our time. So I wanted to brief you with what we are going to do. Welcome all. We are going to study basically, and this is going to be a group study. It's not just I'm going to talk, everyone is going to talk. And I want everyone to talk, even dumb questions. If you feel like they're dumb, ask them, because possible that no one has an answer, and possible that you will get an answer. So let's ask questions. Let's discuss as much as we can. This is not just PGY4 oriented. This is oriented towards pathology practice, and by practice I mean to say that you all are residents. Some of you are attendings here already, and uh, the the final goal of all of you, if you're not already doing that, is to practice. And this is reading is not only going to help you in your boards, but will also help you in practice in long run. So that's what we are going to cater this towards as well. We are going to try to start from basics and go with the practice based as to what we need to know. So what my target based on what I estimated is that first reading will require 4 to 5 months. And why is that? I mean, that looks like it is too much, but it's not really too much, because if you see the breakdown, the Kurt's notes, so what we are going to first have, like every session that we are going to do, for example, in the October, November, December, January, February, that's the five months. So for every month, for every topic, for example, we are starting with GI here. So every topic, we are going to follow Kurt's notes first, and then we are going to have path presenter. We are going to go to path presenter together, and then we are going to have the SP review book from MICE that was recently released from CAP in 2021. So if you really see, based on our agenda, this in real terms talking, this is less time than what should have been given. It's very, very hard to attain this in 4 to 5 months, but we are going to try. Why I say that, I will give you an example. GI, that's our first topic. I was looking into how many pages the Kurt's notes and everything have. So before that, let me tell you. So the timings and dates, they are going to be flexible. And that's why we are all in a WhatsApp group together, so that you need to keep on checking the WhatsApp group. Just make sure that you don't mute this group if you at all want to attend these sessions, because randomly someday I'm going to tell, okay, today's session is cancelled. Randomly some days I'm going to tell, okay, let's do a session today. I'm relatively free and we can do it. So keep an eye on the group messages. Saturday, Sunday, let me mute everyone.
Yeah.
Saturday, Sunday, we are going to have longer sessions. That's what our target is. And we are going to kind of have 8:30 to 10 first session, and then second session 10:30 to 12. So, I mean, we'll try to do something like, like until we are exhausted, if you might say. So, but Saturday, Sunday, you will be usually more of constant here, and the weekdays will really depend on a lot on, like, I am also practicing, and I have I'm full-time working, and it will depend on my schedule as well to some extent. It will always be 4 to 5:30, but some days it will not be there, and some days it will be there, despite that it will be not a Tuesday or Friday. It might be Wednesday, Thursday, or whatever, Monday. So that's that. Zoom link is always going to be this, and I have sent in the WhatsApp group. It's always going to be this. You do not need to put the ID or call in. All you need to do is log in with your system. So let me show you the GI. So these are the Kurt's notes. If anyone doesn't have it, then it's Kurt's notes by .net or .com something. If you just Google Kurt's notes, you will find it. He has written a lot of notes. It's like crazy amount of notes that he has generated, and he has done awesome job. So I got in touch with Kurt, Dr. Kurt, and he said that yes, we can use them, we can record them, and we can read them. So if he said that he might also try to join. Let's see, but I mean, he said that if possible, if he has time, then he might join. Anyway, so if you think the GI tract, I was counting the page numbers of these inflammatory and tumors. If you count these pages, it's almost 80 pages of worth of notes in the GI tract. And then this is our main resource. And then the path presenter. So GI, I was looking, so path presenter is pathpresenter.net. So I'll show you where to go. So you just go to, these are all, these, if you go to com as well, it will take you to net. But these are all our resources, and these are all free to use. So that's something that, and then you go to high yield cases over here, and then you'll see the system wise, and we are going to start with GI. So these are the people who generated this content, awesome content. And so the path presenter, if you're not already, many of you must be already doing this. And if you don't know about it, you just look into a case, and it's a virtual slide. It will open up, and basically you can look into it. So that's what we are going to do. Those will be our fun sessions, apart from the reading sessions from the Kurt notes. These will be our fun sessions. We are going to look it together. We are going to see if we can see what is going on. And then once we are done, we'll go to the case info and we'll see what kind of case it is. So I've already leaked out this case. If you want, you can go through them beforehand. I would suggest let it be a known type of cases so that everyone is fair. Anyway, so those are our two main resources. And then the third resource is the CAP book. So it is available in ebooks CAP section, and also as a paperback. It's called a Surgical Pathology Review. It's the most recent one by Daniel D. Mice. This is a book. I have opened the GIT again. So he has written like kind of notes as well of everything. And I would say he has written more than what is needed for the practice. But these are good notes as well. And what we can do is, because we already have a lot of content, Kurt's notes and Path Presenter itself will be a lot for us to cover, a lot. So this book will only do what things we haven't covered, and also depending on how we are doing time-wise. So this is the third book. If you haven't bought it, I would suggest to buy it. It's a great book. And these three will be our main resources. And all of the session that we are going to do from now till whatever months, we are going to record them. I will post them on YouTube frequently. I would not say that I can post them every day, but I will post them frequently. and you will have access to them. And also because this Zoom will not allow any international participants except for US and Canada. So, I mean, the setting is specifically done like that because we want our practice to be US based, and we don't want the international like recommendations and stuff like that. We want our US recommendations to be followed. So that's why it is like that, US and Canada, and that's why we are going to record it, and so that the international people are not feeling like they are secluded. I'm going to put it on YouTube, and they can read it when they can do it when they get a chance. This will be something good if you don't attend it, but like while you're doing your treadmill or something like that, you just open your YouTube and start watching it or something like that. So that will be good to just listen as well. All right, any questions? Any questions? I hope you were able to hear me. Hello.
Will the YouTube channel just be Ace My Path?
So yes, so if you go to YouTube,
yeah, we were able to hear you all this while.
I was like, okay. So this is the Ace My Path channel. And
Okay.
if you don't know it, I can send you a link in the WhatsApp. And in our channel, we already have some content that is in our, like we did the flow cytometry course. So that is in our channel already. So that's the YouTube. So I'm going to post it on the YouTube. I'm also going to post it into our website. That is acemypath.com. And let me quickly show you. So this is our flow cytometry course. I'm going to make another section for search path review, and it will be basically similar to what we have over here. So you
If
see
you're
that,
talking, we cannot hear you now.
can other guys hear me?
Yeah,
We can hear you.
Okay. Priya, I think there is something wrong with your mic or with your audio. So yeah, so it will be more like this. I will be posting the videos like this, and it will be day wise, something like topic wise, and what we are covering, and everything will be written. And then one thing to note is that if you on that video, you have this YouTube link. So if you click on this YouTube, it will take you to that YouTube session. So if you want, if something is not working very well in your phone on the website or something, you can just click on the YouTube or enlarge it, and it will be visible. So that's that. Any questions? Any further? Let's want to start.
Let's do it.
Let's do it. Okay. All right. So we are trying to be fast here, efficient, and we have target of 80 pages, and probably we'll have a session tomorrow as well. We have target of 80 pages for Kurt's notes for the GI, and today's target should be at least 20 pages. Let's see how much we can finish. Okay. All right. So patterns of GI injury. Inlet patch. Inlet patch is heterotopic gastric mucosa in the esophagus. So that's what they have shown over here. Esophageal duct, muscularis mucosa, stratified squamous mucosa, and then these submucosal glands. And gastric mucosa into the esophagus inlet patch. There can be pancreatic heterotopia or metaplasia as well. And glycogenic acanthosis, so basically epithelial hyperplasia with abundant enlarged superficial glycogenited cells, clinically appears white. So then acute esophagitis, this is important, so that should be intraepithelial, like neutrophils lying somewhere else doesn't count. Intraepithelial neutrophils with erosion or ulceration. GERD, often scattered eosinophils. So eosinophils in GERD should be less than 15 per high power field. And In eosinophilic esophagitis, the mark is more than 20 per high power field. So less than 15 in GERD and more than 20 in eosinophilic esophagitis. So GERD, there will be intracellular edema, basal cell hyperplasia, elongation of vascular papilla, and it is usually near the GE junction, it is worse. Okay, infections. So this is all it is going to be. We are going to read together and we are going to summarize if at all possible. I'm not going to teach here. I'm going to learn with you. So infections, Candida. So look for fungal hyphae. And over here, the fungal hyphae should be in the epithelium again. So that's important to remember that the fungal hyphae should be inside the epithelium. And then HSV, molding MMM, and then CMV, inclusions, medications. Medications look for crystals, resins, spill fragments, and then polarization will help. Eosinophilic esophagitis, as we saw, more than 20 per high power field. Microabscesses, degranulation, often diffuse, worse proximally. So GERD is worse distally, eosinophilic esophagitis is worse proximally. Associated with atopic triad, so asthma, allergies, eczema, and presence with dysphagia, chest pain, food infection, food aversion. Rings or furrows, that's how they can be described. Trachealization, felinization. I don't even know what felinization is. So rings or furrows. And systemic allergy, autoimmune diseases and allergies, medication can also lead to increased eosinophils. And so note, as eosinophilic esophagitis and GERD can appear identical on a single biopsy, close clinical and endoscopic correlation will be often necessary. So we can add this statement if it is not very not very high in eosinophils. Sometimes the eosinophilic esophagitis, they have also classified it as mild, moderate, severe based on the number of eosinophils. He's not going to that detail. Maybe the surgical pathology review might go into that detail. So parakeratosis pattern, superficial squamous cells with retained nuclei. Okay. So GERD, we saw that, we read this already. Candida, we read that it should be inside the epithelium and in the immunosuppressed. Budding yeast for the Candida is not good enough. That's a very important point. You have to have the fungal hyphae, not the budding yeast only. And esophagitis desiccans superficialis, that is called a sloughing esophagitis. Superficial mummified layer with ghost nuclei with variable necrosis and minimal inflammation. Clinically can be quite dramatic with extensive peeling and fissuring. Has been associated with thermal injury, medications, and some autoimmune conditions. Sloughing esophagitis. I have never written my note as sloughing esophagitis. I don't even know if I knew about this term. Superficial mummified layer with ghost nuclei, variable necrosis, minimal inflammation. Okay. Esophageal leukoplakia. So coming to lymphocytic pattern, like that intraepithelial lymphocytes in the esophagus. So intraepithelial lymphocytes can be seen in GERD, lichen planus, graft versus host disease, Crohn's disease, and contact mucositis. And then chronic variable immunodeficiency, celiac disease, dysmotility. So lichen planus, again, so with lichen planus, wherever lichen planus comes, a band-like infiltrate comes. So band-like infiltrate at the junction between epithelium and submucosa. Dyskeratotic keratinocyte, so Sivati bodies are common, associated with cutaneous lichen planus and certain medications and viral infections, often older women, risk of dysplasia and squamous cell carcinoma. So that's what you have to look for in case of if you find that kind of band-like inflammation and in the esophagus. Graft versus host disease. So donor T lymphocytes will attack the host tissue, typically present with rash, diarrhea, elevated LFT. Intraepithelial lymphocytes with dyskeratotic keratinocytes and scattered apoptotic bodies. Make sure CMV IHC is done. Okay. Crohn's, lamina propria for granulomas. Contact mucositis, generalized response to mucosal injury, allergy, medication, food. CVID, celiac disease, and dysmotility. Coming to stomach. So normal histology they are coming to. Oxyntic mucosa and antral mucosa. Oxyntic mucosa is 90% of the stomach that is in the body and fundus. And there will be pink parietal cells, acid and intrinsic factor butyl uptake, and purple chief cells making pepsinogen. And then antral in the distal antrum and cardia. Gastrin secreting G cells only in the antrum, and usually extremely few inflammatory cells, except at the gastric cardia, which commonly has some chronic inflammation. And that's why when you see a GE junction biopsy, you see usually this kind of chronic inflammation. All you can say is there is mild chronic inflammation, or you can say there is mild chronic carditis. But this usually is seen. I have seen so many cases, like I would say 80% of my G junction cases have this kind of inflammation, at least a little. Reactive gastritis or gastropathy. So these sawtooth kind of appearance, corkscrew, foveolar hyperplasia. So this dark appearance, corkscrew appearance, and foveolar hyperplasia. So mucin depletion, edema, minimal inflammation, extension of smooth muscle bands. This is important. So extension of these smooth muscle bands in between the glands, often caused by chemical irritation, bile reflux, medications, NSAIDs, alcohol. Portal hypertensive gastropathy. So over here, the other findings plus dilated vessels in the lamina propria, seen in patients with portal hypertension. Endoscopically, snake skin. I really doubt that anyone is going to describe it like that, any of the surgeon. GAVE is important. Gastric antral vascular ectasia. Looks like watermelon. Fibrin thrombi present in lamina propria capillaries. So lamina propria capillaries, if they are dilated and expanded along with all these features, think of portal hypertensive gastropathy as well as GAVE, and then look for fibrin thrombi in these capillaries to call it GAVE. Okay. Any questions, anything to add so far? Okay. Acute gastritis. So intraepithelial neutrophils, we know about that, often with erosion and ulceration. So H. pylori, acute gastritis is characteristically superficial lymphoplasmacytic inflammation, prominent lymphoid aggregate. So typical feature is that, I mean, neutrophils are usually not seen in case of H. pylori, but not to say that can't happen. Most common in antrum, look hard in pits and consider getting H. pylori. Risk of MALT and dysplasia or carcinoma. Helicobacter hillmanii. So there will be less acute inflammation, more often in kids. Organisms are longer, spiral, less numerous. Medications, NSAIDs, focally enhanced gastritis. Focally injured glands by inflammation can be seen in kids, IBD or Crohn's. Okay. And then CMV. Coming to chronic gastritis, so H. pylori is the known cause most often and most common in the antrum. Next is autoimmune metaplastic atrophic gastritis, also known as autoimmune gastritis. Autoantibodies destroy the parietal cells or oxyntic mucosa, and that will lead to no intrinsic factor, and that will lead to B12 deficiency and pernicious anemia. So what we'll see is in the body, predominant injury with loss of oxyntic mucosa. So when we get our biopsies, they tell them, they usually, for the antrum, they write antrum. For the body, they might or might not, usually not, write that it is coming from body. So what we write in our reports is really what we see. So we'll say that gastric oxyntic mucosa or gastric antral mucosa or whatever. So loss of oxyntic mucosa in the body is one thing. And then deep chronic inflammation, they have shown over here. And then intestinal pyloric metaplasia, ECL cell hyperplasia, and can make neuroendocrine tumors, type 1. Gastric stain can help confirm sample came from body, which will be negative, and not antrum, which will be positive. So I don't know how often does people do gastrin stain in their practices to confirm that. If someone wants to chime in on that and tell their.
Kanksha, how much have you seen AMAG in your practice, and how do you do it? It's one of my thing. Like in my practice, I always like think I'm missing this, and and I do stain, and it never turned out to be AMAG. But in my training, I was told like if you are not seeing AMAG, then you are missing it.
Yeah, that's what I mean. That's why I want to know what other people are doing, because truly speaking, to diagnose conclusively as AMAG is something of a big of a challenge. All I would say is what I see, and I would say that gastric antral mucosa, even if it is a body type place, we'll say gastric antral mucosa with chronic inflammation and H. pylori. But I don't know how frequently people do gastrin. I mean, I very rarely do it, and I, in fact, in my residency as well, I hardly remember a case or two that were suggested of autoimmune gastritis. Like it was not in the top line, but it was suggested. Anyone else has more ideas on this thing?
I have seen quite of AMAG in my residency, like, and that's why I fear in my practice, like, I don't see it. Like, it's like I have not seen it so far. And but like what I saw in my residency was like when you start seeing like kind of an atrophic epithelium, like when you see the glands are being lost, and metaplasia, I haven't encountered, like even in residency, I didn't see that much metaplasia. But like when you start seeing atrophic like this auxentic area, like where you are losing glands and then chronic inflammation, then go for these stains, and then you might like hit it. But I mean, that's all my experiences so far.
Hi, my name is Ghazal Al-Sari. I'm a GI pathologist in California. I do see it actually in my practice. I do stain for gastrin frequently. So what happens is when I get a biopsy from antrum and another biopsy from a body, and the body is completely antralized, it triggers me to do a gastrin to just make sure that it is actually a body that's atrophic. Of course, with intestinal metaplasia, especially when I see IM in the body more than the antrum, and my antrum kind of looked just almost like normal, just a little chronic inflammation, it kind of triggers me to do a gastrin on the body, and boom, it's basically completely negative. My diagnostic line will be chronic atrophic gastritis. And my comment would say, gastrin stain performed and it confirms a body origin of the biopsy in the presence of intestinal metaplasia and Paneth cell metaplasia. This feature can be seen in chronic. This feature is best classified as chronic atrophic gastritis. Differential includes H. pylori versus autoimmune gastritis. This is how I put it, and I basically like to throw a synaptophysin there, confirming that I do have ECSL hyperplasia and I don't have little carcinoids, and I do measurements in case I need to. So yeah, I do see it at least probably twice a month, if that. But I'm purely GI. All I do is GI. So maybe my sample size is biased a little bit.
And maybe we are missing a lot of them. That's the thing. I mean, it's if you see that often, that means it is present that often. And
yeah, I think a very important thing is if your antrum, it does not have IM, and your IM is purely in the body, you have to rule it out. I think this is a very important minor clue, because the antrum in atrophic gastritis is not as affected as the body. Okay.
Right. Got you. Thank you very much. I really appreciate your help.
Sure.
Okay. All right. So we were reading chronic gastritis and medications, NSAIDs, CVID, and ciliaris. Into lymphocytic gastritis, intraepithelial lymphocytes in the stomach. So it can be H. pylori induced, celiac disease, medications, HIV, other immune-mediated disorders, and lymphoma. Just a second. Sorry, you guys, I got disconnected. Can you hear me?
Yeah, we can hear you, Kanksha.
Okay, good. I want to ask the person who was just speaking about chronic atrophic gastritis. Again, can you introduce yourself? I'll write down your name.
Yeah, sure. My name is Ghazal Al-Sati. Last name is Alsaati, and I am a GI pathologist at a private practice lab in South San Francisco. It's called Covenant Pathology. I did
Very nice.
my residency at Georgetown and
Mhm.
fellowship at George Washington, and immediately jumped to practicing GI 5 years ago.
Perfect.
Okay.
Perfect. So I would like your inputs. I would like you to be really chatty. And I would like
Okay.
your inputs. Just don't mind talking in between and interrupting me and teaching whatever you
Oh,
can.
absolutely. Yeah, sure. GI is something I really adore.
That's great. Great to have you here.
Mhm.
Okay. So intraepithelial lymphocytes. So we read H. pylori, celiac disease, medications, HIV, Crohn's, lymphocytic colitis, CVID, lymphoma. Collagenous colitis. So this is important. Collagenous gastritis, sorry, not whenever we say collagenous, it comes in mind, it's colitis, but collagenous gastritis, okay. Increased subepithelial collagen band with intraepithelial lymphocytes. And that can be highlighted with the trichome stain. So it can be associated with collagenous colitis and celiac disease, medications, Helicobacter, and immune-mediated disorders. Coming to eosinophilic gastritis, so increased eosinophils, there's no strict cutoff. However, more than 30 per hyperfield is likely too many, and any in the epithelium, submucosa, or muscle is abnormal. So in the epithelium, submucosa, or muscle, if there are eosinophils, that's abnormal. More than 30 per hyperfield is abnormal. Eosinophilic gastritis, gastroenteritis, diagnosis of exclusion can be associated with eosinophilic rich inflammation in the other organs, for example, eosinophils and or small bowel. Layer of bowel involved determines symptoms. Okay. And then the other causes of eosinophils can be Helicobacter, parasites are important, connective tissue diseases, vasculitis, food allergies, medications, inflammatory bowel disease. All right. Oxyntic gland hyperplasia. So dilated oxyntic gland with hypertrophic parietal cells with snout. Okay, hypertrophic parietal cells with snouts. So if it is single or sporadic polyp, so that could be in the fundic gland polyp, can be present in fundic gland polyp. So associated with proton pump inhibitor use, fundic gland polyps, increased gastrin levels through feedback, causing parietal cell hypertrophy, extremely low risk of dysplasia progression. They are really benign. Innumerable or dysplastic. So a lot of oxyntic gland hyperplasia, if it is seen, it could be seen in other polyposis syndromes. So those could be FAP and then mutated by H associated polyposis, Zollinger-Ellison syndrome, gastrinoma. All right. Foveolar hyperplasia. So corkscrew gland, mucin depletion, edema. So it could be single or sporadic polyp in case of hypoplastic polyp. And there will be associated background inflammatory injury, extremely low risk for dysplasia progression. Again, if they're innumerable or dysplastic, then you have to think of a syndromes. So those will be Meniere's disease, P10, Concite Canada, juvenile polyposis, and Pierce-Jaggers. Small intestine, so checklist. So checklist is that how are the villi, long or skinny, go away or blunt with celiac disease. So are they blunt? And then goblet cells, so they will go away with the autoimmune enteropathy. So look for that. Intraepithelial lymphocytes in celiac. Plasma cells, they will go away with CVID. Oh my God, I don't think I will ever be able to see that there are no plasma cells and hence it is CVID. Critters, look for villi and or surface of giardia. And vessels, okay, look for amyloidosis and vasculitis. And endocrine cells, they will be going away with endocrine dysgenesis. God help us. Okay, so this is a very nice checklist. Endocrine dysgenesis and And the other one was plasma cells. They are going away with CVID. I wish I could highlight these notes. Actually, we can. Wait.
If you download this, maybe you'll be able
Yeah.
to.
Exactly.
Yeah.
Exactly. Yeah, but I don't even know if I have Adobe in this work. No, I don't have Adobe. It will come out like this. That's fine. Okay, so we did this and okay, small intestine. Acute duodenitis. So neutrophils in duodenal epithelium. Okay, if you have your laptops open or computer like work computers open, and if you can download and if you can open it in a PDF, I would encourage highlighting these stuff so that you can go back as well. And you can follow while I'm reading in your own PDF too. So try doing that. Okay, acute duodenitis. So neutrophils in the duodenal epithelium. So that can be in peptic duodenitis, infection, medication, inflammatory bowel disease. Peptic. So for peptic duodenitis, C for gastric foveolar metaplasia and chronic inflammation, and associated with excessive gastric and or helicobacter. All right. So gastric foveolar metaplasia and neutrophils in the epithelium will be more of peptic duodenitis. Infection, so H. pylori, ulcers, peptic ulcer disease, sometimes adenovirus, CMV, and other viruses, and NSAIDs, inflammatory bowel disease. Coming to acute ileitis, so medications, infection, inflammatory bowel diseases again, and Crohn's disease most likely to impact TI, tubulointerstitial. I don't know. So look for granulomas and signs of chronicity, including pyloric gland metaplasia. Okay. In UC, there is typical inflammation in nearby cecum that is also thought to as backwash ileitis. Okay. All right. Eosinophilic gastroenteritis. So again, for gastroenteritis, more than 60 per hyper field is too many. So we read in the stomach that eosinophilic gastritis, more than 30 is too many. These are not real strict cutoffs. This is what maybe Dr. Kurt's own experience or maybe somewhere written as well. But no strict cutoff, more than 60 in the enteric tissue is too many. Any in the epithelium, submucosa, muscle is abnormal. Okay. Eosinophilic gastroenteritis, diagnosis of exclusion, can be associated with eosinophilic rich inflammation in other organs, for example, stomach or colon. And then layer of bowel involved determines symptoms. So basically, if there is mucosa that is involved, there will be diarrhea and malabsorption. If there is muscle involved, so there will be ileus, and serosa involved, ileus and ascites. And then other causes of eosinophils, again, parasites, connective tissue diseases, allergies, medications, IBD, particularly Crohn's. Chronic injury. So now we are going to architectural distortion, crypt branching, dropout, pyloric gland metaplasia, often with villus blunting, and a basal lymphoplasmacytosis. So that starts to look like IBD. That's important one. So basically, the chronic features: crypt branching, dropout, pyloric gland metaplasia, villus blunting, basal lymphoplasmacytosis, and inflammatory bowel disease. So again, there will be active inflammation with cryptitis, crypt abscesses, and particularly in Crohn's and small bowel in general. Look for granulomas to transmural inflammation in resections. Diaphragm disease, that's due to NSAIDs. And so that will also be causing this kind of erosions with acute inflammation. And then multiple episodes can cause scarring, stenosis, usually less chronic inflammation than Crohn's. Coming to medications, mycophenolate. So mycophenolate is an immunosuppressant often given after transplantation, can cause epithelial crypt damage with increased apoptosis, causing diarrhea. Ischemia, severe pain, coagulative necrosis, crypt withering, lamina propria hyalinization, and hemorrhage. Reperfusion brings acute inflammation. Radiation most sensitive to damage, and endothelial injury. So endothelial injury is more often leading to edema, fibrin, ischemic changes, enlarged bizarre nuclei. Graft versus host, again, donor T lymphocytes will attack the host bowel. First, see apoptotic bodies in the crypts. Severe damage shows crypt abscess, crypt distortion, and epithelial destruction. Graft rejection, host T lymphocytes attack the donor bowel. Similar to GVHD, inflammation with crypt destruction and apoptosis. IPAA findings given to patients with UC or FAP, usually not given to Crohn's patients as high risk of complications. What is IPAA? Does anyone know?
It's ileal pouch and anal anastomosis.
Okay, got it. All right. Pouchitis, acute and chronic inflammation of ileal reservoir, unclear etiology, but often treated with antibiotics or probiotics. If refractory, consider Crohn's. Cuphitis, chronic active inflammation of the rectal cuff. So that's the cuphitis and that's the pouchitis. So cuphitis in the rectal cuff attributed to residual or recurrent UC. Lerner system for grading GVHD. All right. So isolated apoptotic bodies is the first grade. Then loss or damage of the isolated crypts with or without crypt abscesses is the second grade, grade 2. Loss of 2 or more contiguous crypts is grade 3. Extensive crypt loss with epithelial destruction is grade 4. Okay. All right. Anyone has anything to add? Any questions? Okay. All right. So coming to celiac disease and other malabsorption syndromes. So malabsorption, there will be villus atrophy and increased intraepithelial lymphocytes. That all we know. Causes diarrhea often with weight loss. So then celiac disease. Gluten exposure triggers the inflammation primarily in the duodenum. Positive serology for antigliadin, tissue transglutaminase, anti-endomysial. If not, IgA deficient. Yeah. And then associated with haplotypes, so those will be actually DQ2, DQ8. Absence both of these essential excludes the diagnosis. Oh, so if you don't have actually DQ2 or DQ8, either of them, then that excludes the diagnosis. Number of IEL typically more than 20 per 100 enterocytes. So you have to tell the count of IEL in your report as well. And typically more than 20 per 100 enterocytes. Crescendo at the tip of villi. Crescendo at the tip of villi. Okay. Other protein sensitivities. Cow milk, soy, eggs. Often increased eosinophils in the mucosa. All right. Peptic duodenitis, medications, small bowel bacterial overgrowth from anaerobic bacteria, often caused by decreased acid and dysmotility, digest bile and carbohydrates, variable local damage and bloating. CBID, so basically we read that the glass muscles will be absent in case of CBID. And then there will be low serum immunoglobulins, recurrent infections, and all of that. Tropical sprue, travel to Africa, Asia, South America. Autoimmune enteropathy, absent goblet or Paneth cells. most often in infants. Oh my God, how often have you guys seen an autoimmune enteropathy with absence of goblet of panicles?
I haven't seen one yet, but I always try to exclude it of how serious this diagnosis is, okay? The doctors will ask you to rule it out. Definitely in practices where you have more pediatric, mine is all adult, but when you have pediatrics, my colleague worked in a hospital where they saw a lot of GI. She said that autoimmune enteropathy is something that on a daily basis they have to rule out. But yeah, I don't see it a lot in adult, but I got a phone call last year about one of my patients. I called, this is most consistent with celiac disease. The doctor calls me back and he goes, the patient is in the ICU. This is how bad it is. It turned out to be autoimmune enteropathy. She was 18 years old. It is very rare, but it's a very serious diagnosis. So always keep in mind when you're looking at your slides to make sure you don't miss it, or you don't, at least put it in the differential.
So what kind of features you would be look out for except for absent goblet cells or panic cells?
It's basically almost like you're looking at a duodenum that looks like a colon, basically. It's pretty much inflamed. Pretty much, I don't have any goblet cells, nothing. It's just completely bland looking, almost like a colon without goblet cells, like almost like an adenoma looking, but not so stratified. And very, very inflamed. The cells are basically entirely lymphocytes. When you have a bad celiac, you almost lose goblet cells in the duodenum. Very similar. Actually, there is no way for you to differentiate between celiac and autoimmune. But if you have to suggest that this is celiac first, and then if the patient comes back usually the biopsies will come back in 10 days or in 2 weeks, the doctor will tell you the patient is not doing well. She is not celiac. Can you re-look into your diagnosis? Can you look at, the patient will keep being biopsied because of the bad watery diarrhea, malabsorption, malnutrition. So you just have to have it there in your differential in the clinical practice.
Got you.
All right. Yeah,
Thank
but
you.
I've only seen it once, and the patient was then hospitalized, and I lost the specimens from them because we only get specimens from clinics, not from hospitals.
Right. Yeah.
Mhm.
Okay. All right. So next is foamy macrophages in the mucosa. So basically MAI, and get a white stain, and then Whipple's disease, get a PASD stain. So Whipple's causes an infection afflicting adult white men. Will cause arthralgias, weight loss, and diarrhea, and treating with antibiotics. And then non-specific. Dilated lacteal. So primary lymphangiectasia, poorly understood, dilated lymphatics, lymph albumin leakage into the gut, diarrhea, and protein losing enteropathy. Secondary lymphangiectasia. Similar manifestations as primary, but secondary to obstruction, tumor adhesions, stricture, and prior surgery.
I have a question for the practicing GI. Yeah, for this dilated lacteal, I see it sometimes. Can this finding be non-specific if it is like 1 or 2 villi which have it
Yeah.
like not this florid?
Yes, it can. So if you have those dilated villi at the base of that villi, not at the top, you can sometimes ignore it. But you see where the location of that lymphatic is at the very top. Even if you have 1 or 2 of these, if they are so distal, mention them, okay? You might be able to have the patient do an abdominal CT and rule out an obstruction of some sort of a mass or a big lymphoma or something, okay? So the location, distal versus proximal in the villi, makes a huge difference. I would never ignore them when they are at the very top.
So how do you sign them out then?
I say duodenal type mucosa with dilated lymphatics, see comment. In my comment, I would say this is non-specific, and it could be seen as it could be a normal histology variant. However, you have to follow up with radiology to exclude legional tissue that may, I have a comment there in my computer that may cause obstruction and dilation of the lymphatics. Okay, and also, of course, infection. You have to make sure there are no histiocytes inside them. You want to make sure that nothing is filled within these lymphatics. Okay.
Yeah. Okay. Yeah. Thank you.
Awesome. Thank you very much.
Sure.
Thank you. All right. So coming to colon. All right. Crypts should be oriented parallel to one another, perpendicular to the surface like test tubes, resting on the muscularis mucosa. Right colon and left colon. Right colon will have more lymphocytes. Paneth cells are normal in the right colon, fewer goblet cells. And left colon has more goblet cells, less lymphocytes, and Paneth cells in the left colon is abnormal. Okay. Some architectural distortion and mucophages in the rectum is considered normal. All right. Focal active colitis, so this in neutrophilic infiltration in the crypt epithelium can be due to NSAIDs. Acute self-limited colitis can be Campylobacter, Salmonella, Shigella, Yersinia. Bowel preparation artifact, ischemic colitis, and IBD. Acute colitis, extensive cryptitis, cryptapsis without the features of chronicity. So that could be infection, as in CMV, Salmonella, Shigella, Campylobacter. So make sure these have been evaluated. Often food contamination, fecal oral, mesoid pseudomembranes in there. And then medications and NSAIDs, and ipilimumab, Kexalate, and cevilimide. IBD, so there will be features of chronicity. So would have to be emerging, very recent onset, or partially treated. Okay. Chronic active colitis. So active with features of chronicity. Features of chronicity will include architectural distortion, crypt branching, loss and shortening, basal lymphoplasmacytosis, Paneth cell or pyloric metaplasia. So think of those test tubes being melted. Okay. So basically crypt branching, distortion, loss, shortening, basal lymphoplasmacytosis, Paneth cell metaplasia, pyloric metaplasia. IBD, chronic systemic autoimmune inflammatory disease. On a mucosal colonic biopsy can be impossible to distinguish Crohn's from UC and must rely on clinical or endoscopic impression. Look for granulomas and dysplasia. And infection, rule out CMV in case of refractory IBD. And okay, do you often do CMV stain in UC or IBD cases?
All the time. All the time.
Yeah.
All the time. You'll be surprised how much it's subtle and it's loaded. Yeah.
And even in case of like if you have focal acute colitis, would you still do it?
No, not if it's focal. If it's focal, no. When I only do it when I have moderate to severe active colitis. If I don't have chronicity. If it's focal, I would run it. But of course, I will look for CMV inclusions on H&E, and I will mention that no CMV present on standard H&E. But once it becomes moderate to severe active colitis, I'll do a CMV. And moderate to severe chronic active, I'll do a CMV. It's very subtle. I also do CMV in patients with inflammatory polyps. And I have few cases basically of patients with CMV infection in gastric polyps in patients with IBD. So it's not only purely in the colon. Yeah. Okay. So always, yeah, it's good to make it a habit to do a CMV very frequently, because it will pop up. I mean, for me in my practice, I probably have a CMV infection one every 2 weeks. Oh, I'm sorry, one every week, once a week. So it's very common. I always throw a CMV. Mhm.
Wow, that's awesome.
I have one more question. Have you seen like eosinophilic predominant inflammatory bowel disease? I have seen like case reports on it, and I had one case, and clinician was very like clinically suspicious for IBD, and
Yeah.
the inflammation predominantly was eosinophils and like few
Yeah.
neutrophilic infiltrate.
So here's the deal. When you see EOS, patient, whatever the history of the patient is, IBD, non-IBD, if you have plenty of EOS, almost like an eosinophilic type biopsy, you do a lot of levels, okay? There, you want to rule out parasite. Okay, and it's very subtle and it's very difficult. And I'm telling you, I have my parasite slide next to me all the time on my scope, because I always want to refresh my eyes of how subtle it is. Number one, and before blaming IBD, before blaming anything, if I have EOS, I have to rule out parasite. Number two, did the patient take medications? If the doctor is suspecting IBD and he treated him as if it's an IBD for 3 months, then the medication will switch the inflammation into the patients from chronic active to eosinophilic rich. Okay, so a treated IBD is eosinophilic rich IBD. So you don't want to label the patient as eosinophilic rich. You will say a chronic active inflammation come up predominantly eosinophils. In your comment, you will mention that you did levels and you excluded parasite, and you will say that this can be seen in prior treatment, and it can be seen as idiopathic and food allergy and all of the differentials of the EOS, okay? But to the eye of the clinician, he has to think outside the box. He has to do OVA and parasite for that patient. He has to be blamed for starting the patient on medication before securing an active, a solid diagnosis, okay?
Yeah, that
All right.
patient did not had any treatment before, because
No
I
treatment.
called the physician and checked, and I didn't see parasite. I did levels too.
Okay,
And
good,
then
good.
Still, I did not call it like right away eosinophilic. I gave differential, but still the clinician treated him as IBD, and I was like kind of surprised, like how much they depend upon their clinical impression. Like even if morphologically I'm not like it's all eosinophilic and I'm not committing to it, still they were treating it as IBD.
Yeah, and did the patient get better?
I
You
lost
don't
that
know.
patient to
Okay,
follow up.
yeah, see, that's the problem with our practices. We kind of suggest we're dying to know what happened, and then we lose those patients. So what I would tell you, my honest opinion as a pathologist, if the patient will be labeled for a long time with what we say on the reports, okay? And if we are not 100% positive, adding a differential is not us being not sure. It's us covering a lot of bases before we label those young, which are usually young, those coming with diarrhea and stuff, with these labels. You don't want a patient who's 19 years old to be IBD, and then a year after he's completely clean and he's been following up for dysplasia for the next 20 years. And it was just an infection. You know what I mean? It's not something fun to go through. So always, don't worry about adding a differential. Adding a differential is something that gives me power. That gives me a power to the clinician, telling him, I have so many things that look like that. Please cover your bases before you go ahead and label your patient to anything. And then I can always suggest to come back in 6 months after inflammation subsides to have a better view of the normal and the abnormal patches. You know what I mean? Like, because it's not a process that you can sign out right away. You're also a clinician who's following a patient. It's not only them.
Okay. So if it's a first time without medication, still IBD would be in your differential if you have eosinophil?
Yes. For sure. No question. Yeah.
Okay. You made me feel better today. I was thinking about that case.
Awesome. I think you should be present in all our discussions, both of you, Shweta and
Man,
and
I'm
Ghazal.
full of questions. I tell you, in my practice, I see all weird stuff.
What are your specialties, girls? It's FIMGI. What about you?
I am a hematopathologist.
Yeah. See, I am completely completely screwed here. I have no idea. I barely can tell, you know, a reactive lymphoid aggregate in a colon versus. So that's why I'm joining this group, and because I really want to refresh my memory and my practice, because I'm purely GI. I do GI, I do cytology, I do pancreatic cytology, but that's the most of it. That's all I do. So I have no idea about neuro, GYN, nothing. So I really need to refresh my mind about these items too.
See, that's why I said there is something for everyone. But I definitely say that you should be here definitely for our sessions, because you seem to have good insights on GI. And
Oh,
that's
sure.
definitely-
I'll try my best to attend all the GIs for sure.
Yes, yes, yes.
Mhm.
And Shweta, you have to attend all the sessions, huh?
Exempt me on weekends, but weekdays I'll try my best.
Yeah, we'll miss you. Okay, let's go ahead. So chronic active colitis, we were reading IBD infection, diverticular disease. I'm muting you, okay? I'm muting everyone. So diverticular disease, most common in older patients in sigmoid colon, may mimic IBD with diverticulitis and segmental colitis associated with diverticulosis. Diversion associated colitis, in bowel diverted from fecal stream, usually see florid lymphoid hyperplasia with prominent germinal centers. Okay. STD proctocolitis. STDs, especially syphilis, LGB, chlamydia, often ton of plasma cells will be there. Okay. Cord colitis syndrome, after umbilical cord transplantation, often see granulomas. Medications, NSAIDs, ipilimumab, and resins. Okay. Ischemic colitis. So superficial epithelial damage, crypt withering, lamina propria hyalinization, and hemorrhage. Occasional pseudomembranes, acute inflammation with reperfusion. Ischemia due to poor perfusion. Most common in the watershed areas, those will be splenic flexure, rectosigmoid, and ileocecal lesions. In older patients with vascular occlusion or low float states. Then coming to ischemic colitis, can also be seen in E. coli and C. difficile. And E. coli, endothelial damage from toxin, fibrin thrombi are often seen, associated with HUS, anemia, low platelets, and renal failure. And C. difficile, pseudomembranes, less hyalinization, and crypt withering. NSAIDs, looks like everything NSAIDs can do. Resins, kexalate, and ipilimumab. Eosinophilic colitis, so again, there is a cutoff, like not no strict cutoff, but more than 60 is too many. And anything in the epithelium, submucosa, muscle is abnormal. Eosinophilic colitis or gastroenteritis, diagnosis of exclusion can be associated with eosinophilic-rich inflammation in other organs, for example, esophagus and or small bowel. Okay. Layer of bowel involved determines the symptoms. Okay. Then parasites, connective tissue diseases, allergies, medications, systemic mastocytosis, and inflammatory bowel disease. So in the systemic mastocytosis, they specifically mentioned in the colon. I don't know if that's something related, because they didn't mention systemic mastocytosis anywhere else. Okay. Lymphocytic colitis, increased intraepithelial lymphocytes. So those could be microscopic or lymphocytic colitis. So there will be watery diarrhea, normal endoscopic findings, increased intraepithelial lymphocytes. So more than 20 per 100 epithelial cells, and classically in the older women. Collagenous colitis. So watery diarrhea, that's the collagenous colitis here. Again, watery diarrhea, normal endoscopic findings. Increased intraepithelial lymphocytes with increased subepithelial collagen. Irregularly thickened, trapping inflammatory cells, vessels, and fibroblasts. Highlight with trichrome stain. Then medications and NSAIDs, olmesartan, SSRI viral infections. Granulomatous colitis, Crohn's, and loose non-necrotizing seen in less than half of the cases. You can see granulomatous reaction to crypt rupture. And then infection, especially if necrotizing, rule out fungi and mycobacteria, look for parasites. Non-specific mucosal injury, medication sarcoidosis, cord colitis syndrome. I have no idea what this is. Diverticular disease, CVID, and chronic granulomatous disease.
I have one more question. This collagenous colitis or lymphocytic colitis is a very common like differential which I see the clinician asking me like on the GI biopsies. What are the thresholds that you use for that collagen thickness? Like, when you make the diagnosis? I mean, some books say measure the thickness, but it's so hard like on biopsy to like measure that.
Okay,
kind of thing.
so when you get a biopsy, you look under the microscope, it's either florid and all over the place, you have thickened collagen, and these are the simple cases you don't worry about. You just very confidently write it down as collagenous colitis, not even a differential. And some places you have patchy, focal, and you have variation of thickness. Now, very important, the location. For collagenous colitis or IBD in general, the best place to make a diagnosis is from the transverse colon. Okay, why? Because the right side colon usually have thickened or more thickened collagen band, normal histology. Okay, and the distal, if the patient has diverticular disease, and if the patient has hyperplastic polyps, if their patient has ischemic changes, the collagen band will look different. So the most ideal area for calling collagenous or IBD is the transverse colon. Okay, number one. If let's say they didn't specify, they said random colon, rule out microscopic colitis. Okay, and if it's that patchy and you don't have it on everything, you can do a trichrome stain, okay? And if the trichrome stain is showing thickening and that thickened area is actually going more deeper into the lamina propria, not only submucosal, so you will actually call this I usually call it patchy thickening of submucosal collagen band, see comment in my comment section. This may be seen in collagenous colitis. If the patient has chronic watery diarrhea, this may represent a microscopic colitis of that particular patient. So I kind of, in my comment, I merge the clinical. So the doctor will actually go and ask the patient, oh, do you have chronic watery diarrhea? Oh, yes. There are some areas in your colon that show it. Let's bring you back next year and let's be more, it could be early or emerging. You know what I mean? Let's bring you back next year. Let's treat you as microscopic. If your things got better, then you're fine. If not, we'll do another biopsy next year. Something like that. But the most ideal is transverse colon. Memorize that. You want it there. You want to avoid calling microscopic colitis on the right side biopsies only. Please avoid that. It's a common mistake. And put it in a differential if it's not very prominent.
Okay.
So
I mostly
I had
get
a
random
question.
biopsies, that what I get, and it's like what you said, like is patchy, that what I see.
Yeah.
And I have seen like some people use this term very loosely. Some pathologists report it loosely, and some are like very stringent, like with the criteria of calling it collagenous colitis or not.
Yeah. Again, when it's patchy, if not all your pieces on the slide show diffuse collagen thickening, I would not call this on my diagnostic line. Okay.
So Dr. Alsati, I just
Yes.
wanted to interrupt because are you faced with situations where you do have focal, patchy collagen thickness and you do not have enough intraepithelial lymphocytes, or do you not use that as an absolute criteria? I just wanted to ask.
So there's, how us pathologists, we feel the slides. I know if it's only me, but you kind of have a feeling when you look at the slide, whether or not it's a diagnosis. I don't know how to put that in words, but sometimes the slide or the case will have enough lymphocytes, not enough collagen, but not enough lymphocytes to call it lymphocytic. You know what I mean? Like it's inflamed but not fully inflamed.
Yeah,
And there's
exactly.
thickening. When you have thickening of the collagen, I completely do not use the term lymphocytic colitis. I do not, because if I have thickening, then it's a collagenous case, not a lymphocytic case. But if I
Okay.
only have lymphocytes and my collagen band is very, very thin, that's when I call it lymphocytic colitis. And by the way, in my experience, I have seen lymphocytic much more than collagenous.
Yeah.
So
Yeah.
that's what I do. I have more lymphocytic than collagenous. But in general, when I'm calling collagenous, I will have a good number of lymphocytes. It's never that clean. If it's very clean, then revisit you revisit your diagnosis. If it's very clean and it's not highly lymphocytic.
I have a
Okay,
question
thank
here,
you.
Dr.
Mhm.
Dr. Alsati, I have a question. So
Sure.
it's a dumb question.
No
It's,
dumb questions.
how do they treat collagenous colitis?
Okay, they do some immunosuppressants because remember, there's a lot, it's like almost like an autoimmune disease. So they will give them some immunosuppressants to get their immunity low and prevent them from having that florid inflammation.
And how do they treat microscopic colitis?
The same thing.
So
Collagenous and microscopic, collagenous and lymphocytic are treated the same. So for the patient, there is no difference in treatment. It's just a label thing. They are treated exactly the same. So even though sometimes in some cases, I would call this highly suspicious for microscopic colitis, see comment. In the comment section, this could be an emerging microscopic colitis because I do have some patchy thickening of collagenous band as well as mild increased lymphocytes. This is not a well-formed microscopic colitis case. Recommend rebiopsy next year to have a more solid diagnosis. Okay, because you can always take a biopsy from a patient who is just starting to have the disease. It's not not always you have that full-blown end result. It's not like you're taking a biopsy from a patient who is 70 years old with 3 years watery diarrhea. Some patients are only 40 or 35 and they're just starting to have that symptoms, And then also very important in your diagnosis, you have to say no features of inflammatory bowel disease seen. Like you have to tell the clinician, I don't have activity. I don't have crypt architectural distortion. I don't have granulomas. Because for the doctor also in his head, he doesn't want to only rule out microscopic. What if he's missing an IBD case? You know what I mean? So always add that a line in your microscopic comment.
And how chronic is this condition? Like once we diagnose it as microscopic colitis, like even if they treat with everything,
I have seen cases of microscopic colitis labeled for 20 years and my colon is completely clean. Okay. And I would say no features of active chronic or microscopic colitis. That's what I would say. So even if the patient has history of microscopic colitis, you will have sometimes bouts of completely normal colon. Okay, which just tells you that it is a very well treated. And by the way, a very good endoscopist, even though he will tell you my colon is normal, a very good endoscopist will tell you in his description, he will tell you some irregularity in the transverse or descending colon, highly suspicious for microscopic colitis. So some clinicians can see microscopic colitis, and that was something very surprising for me because to me, I learned that microscopic colitis should clinically be very normal, but yet I have seen some clinicians who can see it. So that's interesting.
And when you say intraepithelial lymphocytes, do you if it is increased in the crypts or versus the surface epithelium, does that make any difference or
crypts,
is more important?
Deep. Yeah, look deep. The surface is usually, when you see lots of lymphocytes in the surface, I'm not talking about small bowel, of course, I'm talking about colon. When you see lymphocytes in the surface of the colon, this could be from preparation, okay? Yeah, prep injury. So you always have to look deep and pretty much it screams, it tells you there's lots of blue dots in your crypts, what's going on. So you go higher, you will see lamina propria and intraepithelial lymphocytes. But yeah, look at the crypts, not only at the surface.
Okay, thank you.
All right. Sorry, I talk a lot.
No, that's perfect. That's perfect. That's what I need here. I need more people like you.
Sure.
Perfect. Anyone else has any other questions that they want to ask? Okay. So pigments, inorganic material. Iron appears brown and granular on H&E, blue on iron stain. Deposition pattern. So deposition in the lamina propria or macrophages. That means prior mucosal microhemorrhages are present. Coarse crystals at the surface, if they are present, that might be because of iron pill gastritis. And then subtle uniform deposition in the deep glands. That could be because of iron overload. So deep glands is more of iron overload. Surface is more of iron pill gastritis. Lamina propria could be because of the mucosal hemorrhage, microhemorrhages. Resins, Caxylate, Cevilamine, bile acid sequestrants. Caxylate, used to treat hyperkalemia and renal failure, causes ischemic and ulcerative changes linked to fatalities, so urgent diagnosis. Purple on H&E with narrow fish scale pattern. Caxylate. Cevilamine, used to treat hyperphosphatemia in renal failure, associated with mucosal injury again, bright pink to rusty yellow on H&E with irregular fish scale pattern. Bile acid sequestrants. Cholestyramine, binds bile acids, lowers cholesterols. Not associated with injury, but there will be bright pink or orange on H&E with smooth glassy texture. Calcium, dark purple, often cracked on H&E, conchosa, and then can be metastatic in normal tissue due to high serum calcium levels, dystrophic in damaged tissue due to injury or Yttrium labeled microspheres. Wow. Appears uniform, dark, opaque, perfect circles. Oh my God. In my dream, if I could diagnose this, I would be considering myself a great pathologist. Given by interventional radiology as internal radiation therapy for hepatic malignancies. Okay. Often also see radiation injury.
With that classic history, you will be able to say, I think.
Yeah, maybe if I have that history.
And once you see it, you will never forget it.
Yes, exactly.
Yeah,
Exactly.
it is that kind of thing. Yeah.
Yeah, that's true. Yeah, all of these things have actually, if you know and if you see once, then you would never forget them. Yeah. Okay. Melanosis. So coarse brownish black pigment in the cytoplasm of the macrophages consists of deposited lipofuscin. Although classically associated with laxative use, can be seen in any disorder with increased epithelial cell turnover, including constipation. Okay. Tattoo. Very black coarse granules in macrophages, often with foreign body joint cell reaction, used to mark lesions endoscopically for later identification. Mucophages, mucin-containing macrophages in the lamina propria, presumably cleaning after epithelial injury and turnover, very common, especially in the rectum. Air, pseudolipomatosis, empty spaces without a foreign body reaction, attributed to insufflation artifact. No associated nuclei, so it is not fact. Pneumatosis cystoides intestinalis, empty spaces with a foreign body giant cell reaction, which means it happened in vivo, often iatrogenic or infectious cause. Perfect. So we are done with one of them. All right. So we are done with 13 pages. Our target was 20 pages. So if we do this one, then our target for today should be achieved, accomplished. All right. So IBD, normal colon, again, that should be parallel test tubes and perpendicular to the surface, resting on the muscularis mucosa. Right colon, more lymphocytes, Paneth cells are normal in the right colon, are abnormal in the left colon. Fewer goblet cells in the right colon, more goblet cells in the left colon. Some architectural distortion, mucophages in the rectum is considered normal. Intraepithelial lymphocytes or even rare neutrophils over lymphoid follicles is also normal. Yeah, that's true. Patterns of damage in IBD. The inflammation of IBD is characterized by presence or absence of activity, defined as neutrophilic inflammation of the epithelium with epithelial damage. And chronicity, including architectural distortion, basal lymphoplasmacytosis, Paneth cell metaplasia. These words are combined such that you can have active colitis or chronic active colitis or chronic inactive colitis, which is also sometimes called as quiescent colitis. So activity is vehemence with cryptitis and crypt abscesses. And then, so with a new onset, you'll have more of active colitis, untreated IBD, and crypt abscesses will happen in 1 month untreated. So more of active colitis. Chronicity, when you'll start having crypt architectural distortion, shortening, branching, dropout, loss of crypt parallelism, villiform surface, all of this will be chronic active when you have both of these. And then after treatment, there will be chronic inactive colitis. So chronic also you'll have the Paneth metaplasia, hyperplasia, pyloric gland metaplasia, lamina propria, and submucosal fibrosis. And then chronic inactive or quiescent colitis, where you will not have the activity and everything. Okay. IBD is classified either as ulcerative or Crohn's. Ulcerative colitis. So chronic active inflammation, rectum, proceeding proximally in continuous and diffuse pattern. Typical findings, chronic active colitis limited to the mucosa and superficial submucosa with ulceration. Can see deeper inflammation with severe fulminant colitis. Can have increased inflammation in the cecum near appendiceal orifice called as cecal patch. Can have the backwash ileitis in the terminal ileum. Crohn's disease, patchy, transmural, chronic active inflammation in any part of the GIT. Typical finding, transmural inflammation, skip areas, patchy inflammation, granulomas, ulcers, so superficial abscess to fissuring ulcers, muscle and nerve hypertrophy, pyloric gland metaplasia, and fibrosis, strictures, fistulas. Okay. Indeterminate, also known as IBD unclassified. Approximately 10% of the patients will be unclassifiable, often due to extensive pathologic and clinical overlap. Placeholder item is not a specific entity, often due to insufficient data of differential diagnosis, active colitis, focal active colitis. So active colitis differentials include others. So where you have just neutrophilic cryptitis, chronicity is absent. So you have neutrophils in the lamina propria, crypt abscesses, hemorrhage, edema, possible erosions. E. coli, Salmonella, Shigella, Campylobacter viruses. E. coli can have ischemic changes. And also some medications, NSAID, checkpoint inhibitors, may also IBD. Focal active colitis. So there are only focal neutrophilic cryptitis present, chronicity is absent. NSAIDs, bowel prep effect. So bowel prep effect, there will be increase of photosis as well, edema and mucus depletion. And early infection day 0 to 4 after onset. Ischemic changes, often with lamina propria hyalinization and crypt withering. Microscopic colitis. So increased intraepithelial lymphocytes, neutrophil rare to absent. We read about lymphocytic and collagenous, and we had a great discussion. So IEL more than 20 per 100 surface epithelial cells. Collagenous will be 10 to 20 usually per surface epithelial cells, 100 surface. Normal architecture, increase subepithelial collagen. Chronic inflammation in the lamina propria, usually superficial. Here, over here, entraps capillaries and lymphocytes, which will be highlighted by the text. Okay. Additional differential. So ischemic colitis, radiation colitis. Ischemic colitis, you'll see hyalinized lamina propria, withered crypts, minimal inflammation. Radiation colitis, ischemic changes, atypical stromal cells, telangiectatic blood vessels. Diverticular disease-associated colitis in colonic segment with diverticulosis. Diversion colitis, colon isolated from the fecal stream. Follicular lymphoid hypoplasia. Prolapse, fibromuscular hypoplasia. Angulated diamond-shaped crystals. Vasculitis, inflammatory destruction of the vessels and fibrinoid necrosis. Eosinophilic / allergic colitis. That would be more than 60 eosinophils per 10 high power field. Again 60. And few PMNs and absent chronicity. STD of inflammatory and syphilis due to anal receptive intercourse. Lot of ulceration, plasma cells, histiocytes confined to it. Okay, medical management. Usually 2 phases. Induction to induce the remission. Maintenance to maintain the remission. These may use same or different medications or doses. Typical management previously involved step-up therapy, where you start with mild drug, mesalamine, move up to more powerful drug if they fail that drug. However, recent clinical trials have shown a complication-free survival with the top-down model, where you start with more powerful or monoclonal antibody and then go down. So then mesalamine, sulfasalazine, budesonide, prednisolone, azathioprine, 6-mercaptopurine, and tofacitinib are these. I'm not going into detail of these. If you think that it's important, then I'll go into detail. Monoclonal antibodies, adalimumab, infliximab, vedolizumab, and asciminib. All right. Cancer screening, that's important. So ulcerative colitis, nearly 2.4-fold risk, nearly twice risk. And Crohn's disease, 1.9. Inflammation, DNA oxidation damage, cancer, risk proportional to severity or duration of the inflammation. So screening recommendations, first 8 to 10 years after diagnosis, no increased screening. Not enough time for carcinogenesis. Then years 10 to 20 onwards, every 1 to 3 years. Shorter interval with worse, especially with PSC. 20 onwards, 1 to 2 years. Okay. Treatment of dysplasia. With modern techniques, including high definition and chemoendoscopy, most dysplasia is visible. As such, it can be completely resected endoscopically. Once a dysplastic lesion has been resected, in absence of surrounding dysplasia, ongoing meticulous colonoscopic surveillance is appropriate. Proctocolectomy is only recommended if dysplasia if endoscopic resection is not possible, or if non-invasive high-grade dysplasia or adenocarcinoma is found. Non-visible high-grade dysplasia. Pre-malignant and malignant lesions in the IBD. So generally follows stepwise progression. So basically there will be non-neoplastic, low-grade dysplasia, high-grade dysplasia, and adenocarcinoma. However, there will be cases where it appears to go from low-grade to adenocarcinoma very quickly or directly. So conventional dysplasia, look for usual adenomas. And so there is indefinite for dysplasia, low-grade dysplasia, and high-grade dysplasia. So indefinite for dysplasia, unable to classify as definitely reactive versus dysplastic, often atypia in the setting of severe inflammation or ulceration, sometimes surface not present for evaluation.
Akanksha, I just wanted to interrupt a quick question. So Dr. Alsati, for your gastric biopsies also, do you use the same criteria for indefinite for dysplasia, atypia with inflammation?
Okay, this is very interesting question and very challenging in the gastric areas. So the amount of inflammation can be much less in the stomach to call indefinite for dysplasia than the colon, in my opinion. The stomach is very subtle, and there is some foveolar type adenomas that are basically dysplastic. So my threshold for indefinite for dysplasia is much lower in the gastric rather than the colon. I don't know if that answers your question.
Okay. Yeah, no, I'm sorry, this is Nupur and I'm a resident. So I've seen this inter-attending variability like you said, thresholds are different for what they call indefinite for dysphagia. So I just wanted to know your thoughts about it. Thank you.
Yeah, mine is much lower in the gastric than the colon.
Great. Anyone else has any other questions? Okay. So indefinite for dysplasia, in the setting of severe inflammation or ulceration, sometimes surface not present for evaluation. Treat active disease and repeat biopsy in 3 to 12 months. Low-grade dysplasia looks like sporadic adenoma and enlarged hyperchromatic smooth pencilate nuclei, pseudostratified nuclei with basal orientation, higher NC ratios, little or no surface maturation, often abrupt transition corresponding to the clone, and prominent apoptosis. Molecular IBD-associated dysplasia show more copy number aberrations and aneuploidy than sporadic adenomas. TP53 mutations are very frequently present early, possible reflecting a fast progression towards cancer. Management, complete endoscopic resection is feasible. Otherwise, proctocolectomy and IPAA to exclude the cancer. Try using a lymphocyte as what it is normochromatic. Okay. High-grade dysplasia. So now here we have enlarged hyperchromatic pleomorphic nuclei, often plumper than the LGD. Irregular nuclear contours, prominent nucleoli, loss of nuclear polarity, complex architecture with cribriforming, crypt, branching, or budding. P53 staining often highlights both grades. And dysplasia, strong P53 staining or null type at the surface in the apical areas. Negative or indefinite, weak staining at the bottom of the crypts, proliferative compartment, without strong staining in the surface. Can you give your opinion about P53 stain in dysplasia?
I actually don't stain at all. For me, I never stained any of my cases to look for dysplasia. I don't use that stain. I'm sorry.
Right, me too. I mean, I have never used it.
Yeah.
Anyone else uses it?
Can I just add something? I think MGH, which is Mass General Hospital at Harvard, they use, and we also use at our institution when we are iffy between that if it is due to inflammation or it's actually high-grade dysplasia. And if you want, I can share a very good. It's a small, 30 seconds video that has been uploaded by Dr. Vikram Deshpande on Twitter, and he tells the usefulness of P53. And actually, from that video, I learned a lot. So I'll share it in the group.
Oh,
Yeah,
that'll be
sure.
great. Thank you very much.
Welcome.
Thanks, Anthony. Okay, so basically, strong P53 at the surface in the atypical areas, that is dysplastic, and weak staining at the bottom of the crypts, that is the proliferative compartment, without strong staining in the surface, is negative or indefinite. Okay, H&E still goes standard, of course. Non-conventional lesions, so serrated epithelial change, serrations top and bottom of the crypts, distorted crypt architecture where some crypts do not reach the muscularis mucosa, unlike SSL, normal nuclei, goblet cell-rich epithelium. Controversial risk of CRC, many studies show increased risk of dysplasia carcinoma, and likely P53 mutations can be there. And colon and IBD patients can frequently show surface serrations, hyperplasia, particularly in distal colon, cystic criteria. So serrations at top and bottom of the crypts, and then distorted crypt architecture where some crypts do not reach the muscularis mucosa. Okay. Non-conventional dysplasia may be present with conventional dysplasia in nearly 50% of the cases, more common in the left side of as a polypoid mass. So here we have hypermucinosis, villus architecture with prominent cytoplasmic mucin. Okay. TSA-like, SSA-like, Paneth cell differentiation, goblet cell deficient, terminal epithelial differentiation, TED, or crypt cell dysplasia. The crypt cell dysplasia will be flat lesions, round to oval hyperchromatic nuclei just in the crypts. adenocarcinoma, invasive through the basement membrane, infiltrating glands or cells, broad, expansive, confluent growth of glands. Compared to sporadic, IBD-associated CRC is more often multifocal and higher grade, advanced stage, signet ring or measles. Unique variant, low-grade tuberocrandular adenocarcinoma, very small, very bland, small to medium-sized round glands that invade with little desmoplastic stroma, often CK7 positive, frequent IDH1 mutations. Okay, that's it. All right, so it's 5:30 and we are right on time. We did 20 pages, approximately 1 page short, and we are going right on time. So next time I'm gonna post in the group, we are going to do medication GIT. So medication is, let's see, is 7 pages, and GI infections is another 8 pages, so 15. And Hirschsprung's disease. So this is what our target will be, to medication GI and Hirschsprung's, and maybe starting with the tumors. All right, thank you very much, everyone, for joining.
Thank you for a very
Thank
good
you all.
discussion.
Thank you.
Thank you, Dr. Alsati. Thank you, Shraddha.
No,
Thanks.
sure, no
Nicole.
problem.
Yeah, thank you.
Akansha?
Yeah.
I'm not able to share it because it's a GIF. So, but you know, if you go to his Twitter page and then if you click on media, then you'll be able to see all the GIFs and small videos that he
But
made.
you can share the tweet itself, no?
You mean retweet?
No, the tweet itself, like the link of the tweet.
Yeah.
Oh,
Or
okay.
just tag one of us there, Hansini.
Okay, yeah. I'll share the tweet.
Yeah. Just share the link of the tweet. You'll
Uh-huh.
find it.
Sure.
All right, guys. Bye-bye.
Bye.
Thank you. Bye.